My dear students and friends, in this video, I am going to discuss some points about therapeutic plasma exchange and its role in the intensive care unit. Now, we sometimes tend to use the terms plasmapheresis for plasma exchange or therapeutic plasma exchange interchangeably. So, we have to understand that the two terminologies are not synonymous. There is a mild difference in that. Plasmapheresis is removal of plasma from blood with or without replacement, while plasma exchange is the removal of patient's plasma and replacement with either donor plasma or albumin. Although this plasmapheresis is very old, it was discovered in 1902, but yet it took nearly 50 years in 1952 when it was clinically applied to treat a patient with multiple myeloma. Now, during this whole process, a lot of modifications, a lot of changes in the technology, in the technological advancements have contributed in either addition and deletion of the steps. But over and all, there is no doubt that this is a very useful technology in selected patients when used timely and when used with proper precautions. This can definitely produce excellent results and even dramatic results in some conditions. So the extracorporeal circuit separates plasma from the plasma components. This is when it is a membrane filtration, and discards the patient's plasma and replaces with substitute fluid, thereby reducing the concentration of the harmful plasma constituents that need elimination. And these substances are removed, which are circulating in plasma, and they may be autoantibodies, they may be immune complexes, complement components, cryoglobulins, endotoxins, or cytokines, which are there in severe sepsis and septic shock. So in ICU practice, when we use the term plasmapheresis, it often refers to therapeutic plasma exchange. Although, as I said, technically the later term is only for therapeutic form, and there are diagnostic applications of plasma exchange too. But just as a saying, it is often termed as TPE. Now, what are the steps of therapeutic plasma exchange? As we can see in this schematic diagram, first, it is the separation of the whole blood into plasma and cellular compartment. In components, there is a plasma separator, which you can see down below. And it is then the removal of the patient's plasma, which contains the pathological substances, replacement with appropriate fluids, that is either albumin, saline, or donor plasma. Albumin and donor plasma are common. And then return of the cellular compartment of components plus replacement fluid to the patient. Now, although this is, theoretically it sounds so simple, it is not a very simple, and it is just like any other extracorporeal process, that all care must be taken for both the incoming and the outgoing components. So the steps involved in the therapeutic plasma exchange include broadly the 6 steps. First is the priming, where we fill the extracorporeal circuit with saline or albumin to avoid air and dilution effects. Second is initiation, which is to connect to the patient's central line and adjust the flow rate, say, depending upon the modus operandi. And then the plasma separation, where blood passes through the separator and the plasma is diverted to waste. The cells are recombined with the replacement fluid. Then is monitoring, that is continuous observation of vitals, flow pressure, citrate infusion rate, ionized calcium, to ensure that metabolic milieu is maintained. Then termination, after target exchange volume, the circuit is flushed and blood is returned. Post procedure, we have to check calcium, fibrinogen, coagulation profile, as well as clinically examine the patient's symptoms. What about the duration? It is done for 2 to 3 hours per session, and the frequency can be either daily or every 48 hours, depending upon the indication of the case. Now, what is the difference between this membrane-bound therapeutic plasma exchange and centrifugal? As the name implies, in centrifugal, the mechanism is centrifugation, in which at a high speed it is rotated and the central compartments tend to spread out centrally, whereas the others plasma peripherally. In membrane TPE, it is the membrane capillary filtration, which is the mechanism. The blood flow required in case of centrifugal, it is 10 to 150 milliliters per minute, with the range is wide, whereas high flows are required in membrane therapeutic plasma exchange. The separation mechanism is by gravity. In centrifugation, where it is in membrane, it is with the molecular size, because that's how the diffusion works. Anticoagulant used is citrate. In centrifuge TPE, it can be citrate or heparin or even no anticoagulation in case of membrane TPE. Vascular access, it could be a peripheral vein. More than 30% require central access, though, in case of centrifugal TPE. But the membrane TPE requires central access because that allows high flows and prolonged treatments. Now, one thing we have to know is how to calculate the plasma volume. Typical exchange volume, when we talk about plasma exchange, is 1 to 1.5 plasma volumes per session, which corresponds to around 40 to 60 mL per kg body weight. So for an adult weighing 70 kg, this translates to around 2.8 to 4.2 liters per session. So now when we look into the formula, the plasma volume is 0.07 multiplied by 1 minus hematocrit into body weight. So 70 kg of a patient with a hematocrit of 0.4, the plasma volume calculated will be 0.07 multiplied by 1.1 minus 0.4, which is 0.6, multiplied by his weight, which is 70. So that comes to 2.94, and roughly can be considered as 3 liters, which is required to remove 65% of the plasma components, exchange of one volume of 3 liters. So for 85 to 90% of the removal of the plasma components, the exchange volume will be 1.5 volumes. So with that will roughly be around 4.5 liters. So this is just a simple example on how to calculate the amount of plasma volume that needs to be exchanged. Now, as I said, the anticoagulation has to be there because the blood is running outside the body, and in order to prevent clotting, we have to give anticoagulant. So either it can be a citrate, a CDA. The mechanism is that the citrate chelates calcium and prevents clotting, and it has a short half-life, it has less bleeding, and it is preferred. The other choice is heparin, which inhibits thrombin, and if citrate is contraindicated, such as in liver failure, this can be an alternative choice. The third can be that there should be no anticoagulation. That is possible in high bleeding risk with low flow rates, but they have to run only for short runs, because after that the filter will not work, but the filter will clot and it will become ineffective. And whenever citrate is used as the anticoagulant, if there is toxicity, it can manifest as tingling, hypotension, or hypocalcemia. And this citrate toxicity can be prevented by calcium gluconate infusion during the period. Next question would be that what are the different replacement fluids and their properties in the context of therapeutic plasma exchange? One is the 5% albumin, which is used in most autoimmune or toxin-related indications. Its major advantage is that it is safe, there is no infection risk, but disadvantages are also there, like they lack clotting factors, may cause coagulopathy, etc. FFP or fresh frozen plasma is another replacement fluid which can be used in TTP, liver failure, DIC. The advantage being that it replenishes Adams 13 and clotting factors. And the disadvantage is that there can be transfusion reactions as well as volume overload. Fourth is a combination, that is albumin plus FFP. This is used in ANCA vasculitis, mixed indications, etc. The advantages is that has a balanced approach, but the disadvantage being that it also requires careful monitoring. Saline 0.9% can be used only for priming or volume balance. The advantage is that it has minimal antigen exposure. The disadvantage is that it cannot be truly considered as a replacement fluid. So then how do you monitor a patient who is undergoing therapeutic plasma exchange? One, you look for the vital signs every 15 to 30 minutes, watch for hypotension, anaphylaxis, etc. If there is any, if you give the necessary treatment. Ionized calcium, it should be maintained at more than 1 millimole per liter, and if it gets reduced than this, it should be replaced. Coagulation profile, PT-INR, fibrinogen, post-session platelets, they should be monitored. The lab trends for LDH, creatinine, antibody titers, this is important to assess response. Fluid balance, we should avoid net overload or deficit, that both extremes should be avoided. And clinical response, like in case of neurological response should be as important, like in GBS and in myasthenia gravis. Hematological responses are important in TTP, and hemodynamic responses are important when the patient is brought in a state of shock. Next is that what are the common challenges that are encountered during the procedure of therapeutic plasma exchange? First, one most common challenge is hemodynamic stability, the reason for which is rapid plasma removal producing decreased preload. So the solution to such problem is to slow the exchange rate and give albumin-based replacement. Second is if it is going on with concurrent CRRT or ECMO, then there can be circuit interference, and the solution would be to go for a sequential or parallel correction with multidisciplinary coordination is required. Third is the bleeding risk. Bleeding risk can be because of loss of coagulation factors, and we can use FFP as replacement, monitor INR and fibrinogen. Next is the hypocalcemia. Then that is because of citrate chelation, and the solution is in providing continuous calcium infusion. Filter clotting, either high hematocrit or poor anticoagulation. So this is probably a very common mistake, common challenge or a common problem which is encountered, although it is not expected, but it is more, despite not being expected, it is quite common. And the solution is to optimize the anticoagulant dose. There are certain risks also during the procedure, particularly if the procedure is continued for a long time. First, it can be vascular complications like catheter infection, thrombosis, etc. And to prevent that and to manage in case of occurrence of any such complication, aseptic technique should be followed and care bundles should be adopted. Second is the metabolic. Metabolic, it can be because of hypocalcemia due to citrate toxicity or hypokalemia. And preventive and management strategies should include calcium infusion during citrate use. Third risk or complication is allergic, which may occur because of FFP reactions and anaphylaxis, and pre-medication with antihistamines are helpful. Hemodynamic, there can be hypotension, and in such cases, the recommended management strategy is to slow the exchange and use albumin. And last but not the least, coagulopathy may occur because of loss of clotting factors, and the prevention or management for coagulopathy is to replace with plasma when indicated. Now, there are various indications of therapeutic plasma exchange in the ICU. The list is only a glimpse of a larger picture. For example, when we talk about autoimmune neurological disorders, Then Guillain-Barré syndrome, myasthenia gravis, autoimmune encephalitis. In all these conditions, it is useful for removing the pathogenic antibodies. Hematological emergencies like TTP, atypical hemolytic uremic syndrome, hyperviscosity syndrome like Waldenstrom's macroglobulinemia, all of in this, there can removes the ADAMTS 13 inhibitors of the paraproteins and it becomes useful. In renal or immunological conditions like anti-GBM disease, ANCA-associated vasculitis, also it is useful to remove the pathogenic antibodies and immune complexes. Sepsis-related or cytokine storm states like septic shock refractory to therapy following COVID-19 cytokine storm, which removes cytokines, endotoxins, and the dams. Next is toxin or drug overdose like Amanita mushroom poisoning, Wilson's disease, certain antibody-bound drugs. There also there is an indication and we can remove the circulating toxins. In hepatic failure, acute liver failure as bridge to transplant, this can be a supporting for and alongside with the removal of ammonia, bilirubin, and cytokines. Transplantation, that is antibody-mediated rejection or ABO-incompatible organ transplant. So in that case also it removes the donor-specific antibodies. In other critical dermatological conditions like the toxic epidermal necrolysis, although it's experimental, in that case also it will be useful to remove the inflammatory mediators. Now, American Society for Apheresis have given a classification, and this classification is followed almost in every part of the world, but there is scope for debate on these. Like category 1, this is regarded as a first-line therapy, and examples include thrombotic thrombocytopenic purpura, GBS, myasthenic crisis, etc. The second category is adjunct or second-line therapy, and the conditions include Goodpasture syndrome, ANCA vasculitis, etc. Sometimes the role is uncertain, and on case by case, it can be reached, and that is particularly example which applies for sepsis, autoimmune encephalitis, SLE nephritis, as well as idiopathic thrombocytopenia. So, what are the proposed benefits cited in TPE in therapeutic plasma exchange in sepsis and the MODS? One is that it removes the cytokines, IL-6, TNF-alpha, replaces coagulation and complement factors, improves hemodynamics and lactate clearance, and reduces vasopressor requirement. Even clinical trials have shown improved survival trends, although evidence remains only from low to moderate in quality. So we should use it in early septic shock with multi-organ dysfunction when standard therapies fail, and preferably it should be used as part of multimodal extracorporeal approach. Now, even when we continue to do for therapeutic plasma exchange after some time, how do we know that it is efficacious? What are the indicators of the efficacy? So in case of TTP, the marker of response, that is the platelet count, will go up, the LDH will come down. In GBS, can be myasthenia gravis, the marker of response is the improved muscle strength, reduced ventilation need. In cases of Goodpasture syndrome, again, the marker of response can be reduced in the anti-GBM antibody titers. In vasculitis, again, it is reduced ANCA titers, improved renal function. In case of sepsis or MODS, reduced lactate, reduced vasopressor need, and improved SOFA score. So its safe execution in the ICU demands meticulous technical setup, multidisciplinary coordination, and real-time monitoring. So when we look into the key messages, we find that therapeutic plasma exchange the concept is based upon rapid immunological control, and its ICU relevance is that it can be explored further for treating patients with GBS, TTP, myasthenic crisis, and vasculitis. It can be a good bridge to definite therapy, particularly with liver transplant and antibody desensitization. It can rescue in cytokine storm or refractory shock, and the relevance in ICU is that it removes the pro-inflammatory mediators. The concept is that requires specialized setup. The ICU relevance is central access monitoring and replacement fluids are important and needs to be present, and always we have essential for safe and effective delivery. It has to be reasoned out and remembered always that plasma exchange in the ICU is both a diagnostic and therapeutic tool. It is a bridge that buys time for the immune system and the definitive therapies to act. Thank you very much.